So we have a 62-year-old woman with abdominal pain coming into the emergency department. The possibilities are almost endless. Let's use more information in the question stem about her to narrow the diagnosis down. Hmm. Well, her nausea and diarrhea don't really narrow things very much. The pain has only been going on for 3 hours, and before that she was fine, so something clearly just happened. She does have a history of atrial fibrillation, and she's not on her blood thinner at this time. Maybe that's a big clue. Could she have thrown a clot? She's complaining of severe abdominal pain, but her abdominal exam doesn't seem to have much there. Some mild distension, but she's minimally tender. And there's no rebound tenderness or any guarding. We could call that a benign exam. She's tachycardic, but is not having a fever. And her blood pressure seems fairly normal. She has a mild leukocytosis of 12.5, but the rest of her labs look okay. This is a pretty classic presentation for someone experiencing acute mesenteric ischemia. The keys to identifying her diagnosis in this case here are her pain out of proportion to her physical exam and her paroxysmal atrial fibrillation, a big risk factor for forming a thrombus in her heart and then embolizing this to the arteries that supply her intestines. Intestinal ischemia. Sometimes it affects the small intestine, sometimes the large. Maybe there's an arterial occlusion. Maybe there's a venous occlusion. And just maybe, there's no occlusion at all. Just hypoperfusion because of vasospasm. Imagine that. Welcome to Day of the Dead colon. No dilly-dallying. Rapid diagnosis of acute mesenteric ischemia is crucial because before you know it, ischemia turns to infarction and perforation, which causes sepsis, and finally, muerte. We'll have to keep a close eye on our patient while we chat. This could get really bad for her really fast. First up, a little anatomy. There are 3 branches off the aorta that make up the blood supply to the gastrointestinal tract: the celiac trunk, superior mesenteric artery, and inferior mesenteric artery. The 3 pallbearers that you see here. The celiac artery branches to the common hepatic, splenic, and left gastric arteries, which supply the stomach and duodenum, as well as other organs that aren't really part of the discussion of mesenteric ischemia. The superior mesenteric artery, or SMA, supplies both the small bowel and half of the large bowel. The inferior pancreatic duodenal branch, along with the jejunal and ileal arteries, feed the small intestine. You've also got the ileocolic artery, which supplies the terminal ileum and proximal right colon, the right colic artery that feeds the right colon, and finally, the middle colic artery that feeds the transverse colon. Yep, the SMA is a biggie. And to find it during surgery, go to the base of the transverse mesocolon. Lift it up, like our friend the pallbearer is lifting his hat, and find where the middle colic artery is popping out. Right underneath is the origin of the SMA, which you can see here is the red line. And finally, the inferior mesenteric artery, or IMA. This time we're branching to the left colic artery, sigmoid artery, and the superior rectal artery, which supply the colon from the splenic flexure all the way to the superior rectum, as depicted by this left-sided colonic dress. Because both the small and large bowel are supplied by these vessels, both the small intestine and the colon can become ischemic. If the ischemia is in the small intestine, it's called mesenteric ischemia. If the ischemia is in the colon, it's called colonic ischemia. You may also hear the term ischemic colitis. Alright, now that we know where the ischemia can occur, let's look at why. And we'll start with mesenteric ischemia. First thing to know about acute mesenteric ischemia is, well, that it's acute. Bam! Before you know it, your small bowel is muertos. Acute mesenteric ischemia is a surgical emergency with a mortality rate of around 60 to 90%. There are a few reasons why acute mesenteric ischemia occurs, which can be boiled down to occlusive and non-occlusive causes. Next to this road closure sign, let's talk about the different types of occlusions. The most common occlusive etiology is embolic, accounting for 40 to 50% of causes. The embolism usually comes from the heart. Just think of the disorganized blood flow in the heart chamber of that patient with AFib or recent MI. Or how about the crusty valves of that patient with endocarditis or valvular disease? Psh, what about ventricular aneurysm or aortic aneurysm? These all provide the perfect environment for clot formation. A piece of the thrombus then dislodges and travels into arterial structures anywhere in the body, including the mesenteric arteries. Back to our case. Remember that the patient has a history of AFib? Well, that's just a perfect and very common cause of acute mesenteric ischemia. And note that she's not on any blood thinner. She stopped her Coumadin for her colonoscopy, so there's nothing to prevent her from forming a clot. The SMA is the most common artery affected because of its large diameter, and because it branches at such a narrow angle, compared to the celiac or IMA, that is. Stuff just flies right in there. Boop! Atheroembolism can also complicate vascular procedures such as cardiac catheterization or aortic manipulation during surgery. Kinda like all those embolic cheese drips coming from that vascular burrito. Delicioso! Abdominal pain in the postoperative period after surgeries, especially certain vascular surgeries, can definitely be acute mesenteric ischemia. After embolus, the next most common cause of occlusive mesenteric ischemia is thrombosis right inside the artery itself. Thrombotic mesenteric ischemia accounts for about 25% of acute cases. Instead of an embolus clogging the mesenteric arteries, think of it as a heart attack of the gut. A vulnerable plaque ruptures, resulting in thrombosis and occlusion of a mesenteric artery. Just think of this rupturing pile of marigolds, leading to thrombosis of the surrounding area. Thrombotic ischemia usually occurs in the setting of atherosclerotic disease, or a hypercoagulable state such as polycythemia. Though there are other causes of thrombosis to consider, such as infection, aneurysm, trauma, and surgery. As shown by these drippy atherosclerotic candles and old pictures of previous De los Muertos celebrations. Remember that these patients usually have risk factors for atherosclerosis and a history of chronic mesenteric ischemia, which makes sense when you imagine how long they must have been dealing with those atherosclerotic mesenteric arteries. It's actually quite rare for patients with atherosclerosis of the mesenteric arteries to exhibit symptoms of acute thrombosis due to the abundance of collaterals that develop to compensate for chronic hypoperfusion, as evoked by these growing red collateral shrubs. When an acute thrombotic ischemia does occur in these patients, it typically involves at least 2 major vessels. Okay, one more occlusive etiology of mesenteric ischemia to cover. This time, it's a vein instead of an artery. Mesenteric venous thrombosis accounts for only about 5% of cases and is associated with hypercoagulable states, malignancy, or prior abdominal surgery. Yep, that's a cancer crab piñata hanging from a blue venous rope. And that's a scalpel. Well, I guess that's one way to do it. Alright, next up, non-occlusive mesenteric ischemia. Instead of arterial occlusion, what we have here is a reduction in arterial flow. It accounts for 5 to 15% of acute cases, and again, it's the superior mesenteric artery that is most commonly involved. In critically ill hospitalized patients with prolonged hypotension, excessive vasoconstriction or spasm of the SMA leads to ischemia of the small intestines and proximal colon. Watch out for that patient with severe cardiovascular disease and a complication causing hypotension, such as shock from hypovolemia from trauma, or an MI causing cardiogenic shock or severe septic shock. And on top of that, add medications. Many agents that are used for inotropic and blood pressure support also cause splanchnic vasoconstriction, thus reducing intestinal perfusion. This includes norepinephrine, digoxin, and dopamine. Alright, all these categories of mesenteric ischemia predominantly affect the small intestine. Our last category, colonic ischemia, affects, well, the colon. You may also hear the term ischemic colitis. Mesenteric ischemia and ischemic colitis are different disease processes, so they often get confused. Let's look at how they are different. Compared to the small intestine, the colon receives less blood. In addition, the collateral circulation of the colon is poorly developed. None of those fancy arcades, just a single marginal artery of Drummond to connect the blood supply. So, the colon is more prone to non-occlusive ischemia during low flow states. Vulnerable areas with few collaterals are called watershed areas. One major watershed exists at the splenic flexure, which marks the border of the SMA and IMA circulations, while the other major watershed involves the rectosigmoid junction, where the last sigmoid arterial branch has a tenuous connection with the superior rectal artery. With this in mind, remember that all the same risk factors for occlusive mesenteric disease also pertain to occlusive colonic ischemia, including cardiac arrhythmia promoting embolic ischemia, or atherosclerosis causing thrombosis. It's just much more rare than non-occlusive colonic ischemia due to hypoperfusion. In fact, non-occlusive colonic ischemia is the most frequent form of intestinal ischemia. The prototypical patient with colonic ischemia is elderly and either undergoing a procedure that causes a transient reduction in blood flow to the colon, such as aortic surgery, cardiopulmonary bypass, or hemodialysis, or has had a recent MI, or, any form of shock, really. Man, look at this guy. Wouldn't it suck to have an MI while you're on the pot? Or this patient is on a drug that reduces colonic blood flow. Examples include some immunomodulatory therapies. Illicit drugs like cocaine. That cocaine coffee is probably why he had an MI on the pooper. And even constipation-inducing drugs. Yep, distend the lumen too much, and you've effectively applied a tourniquet to your colon. Alright, let's talk about clinical presentation. Starting with the mesenteric pathologies, and finishing with colonic ischemia. The signs of acute mesenteric ischemia are, unfortunately, pretty nonspecific, meaning that recognizing mesenteric ischemia can be pretty tough. We're usually looking at an older patient here, with severe diffuse persistent abdominal pain, classically described as out of proportion to the physical exam, like we talked about during the case. So just like this hombre who can't quite tell what's wrong with El Santo over here, the patient will nevertheless be in dolor severo. Calm down, dude. Diarrhea, nausea, and vomiting are also common symptoms. Muestra un poco de decoro, amigo mío. If ischemia progresses, it overtakes the entire thickness of the bowel wall, transmural infarction, in other words, as symbolized by the black stain encompassing the full thickness of the tablecloth. Transmural infarction shows up on an exam as diminished bowel sounds due to ileus, as well as peritoneal signs. We're talking rigidity, rebound, and guarding. All signs of peritoneal irritation. And finally, perforation, sepsis, and shock. Bad. For acute mesenteric ischemia, mortality rates exceed 60%. Alright, how about the colonic version of this? Well, remember the location of those watershed areas? Patients with acute colonic ischemia usually presents with mild cramping, abdominal pain, and tenderness on the left side, which is why we've placed this crampy old dude underneath those rusty watershed areas. Also, compared with mesenteric ischemia, colonic ischemia is more often associated with bloody and/or loose stools. In fact, it's not uncommon for patients to present with bloody diarrhea only, and no pain, which is termed the hyperactive phase. The hyperactive phase is then followed by a paralytic phase marked by ileus, distension, and reduced bowel sounds. And finally, in 10 to 20% of patients, there is the septic shock phase, when massive amounts of fluid and proteins start to leak from the damaged mucosa. Regarding labs, they're also pretty nonspecific for both mesenteric and colonic ischemia. Lactate dehydrogenase, creatine phosphokinase, or amylase may increase in the setting of advanced tissue damage. A white blood cell count above 20,000, along with metabolic acidosis, due to lactic acidosis in the setting of anaerobic respiration, is highly suggestive of intestinal infarction. Hence the spoiled milk spilling from the fridge, the recurring Sketchy symbol for lactic acid. In general, any patient with acute severe abdominal pain, elevated white count, and metabolic acidosis has mesenteric ischemia until proven otherwise. Suspect mesenteric ischemia? That second part of the clinical case is asking what the next step is. Well, we need a little more information before we can decide what to do for our patient. So the next step is going to imaging. In general, X-ray is pretty nonspecific, and in a quarter of patients, absolutely normal. But in that unstable septic patient, clinical signs in X-ray is all you have. Pretty much all you can do is look for free air, indicating perforation, or other signs of advanced ischemia, such as distended bowel loops due to ileus, bowel wall thickening, or air in the intestinal wall. We will illustrate these findings in more detail a little later. Remember when we said that we'd have to keep a close eye on our patient? What if an hour after she comes in, her abdomen gets rigid and hard, starts having tenderness and guarding, her tachycardia increases to 115 BPM, and her temperature goes up to 101 Fahrenheit? Well, that sounds like she's getting really sick and progressing towards sepsis, and she may have perforated her bowel. Just keep in mind that, regardless of etiology, any immediate signs of completely infarcted bowel or perforated bowel on imaging, labs, or exam, especially peritoneal signs, upgrades your patient to a first-class ticket to the OR for exploratory laparotomy. Just think about all these signs around the transmurally infarcted table here. That's why we've placed this unstable and necrotic Grim Reaper grave nearby, with his scalpel and all. It's surgery time. For most stable patients, more imaging is required. The diagnostic test of choice is CT angiography, so we've brought in our recurring black CT cat, with yin-yang collar representing contrast. IV contrast, that is. The sagittal projection, by the way, will provide the best view for the celiac and SMA vessels. MR angiography is used as well, and is especially useful in the setting of mesenteric vein thrombosis, or in patients with contrast allergy. Here's what to look for on that CT. Starting with the bowel wall, areas of bowel wall thickening, or where the bowel wall looks darker than other parts of the bowel wall, which is termed non-enhancement and represents lack of blood flow because there is no contrast to enhance the bowel wall. You may even see air in the wall, also called intestinal pneumatosis. How about the veins? Look for gas in the portal veins or thrombosis in the portal system. We've chosen this Venus blue candle to represent the veins, smoking to represent gas in the veins or walls, and then the marigolds to represent the thrombosis. And don't forget about the arteries. Look for mesenteric arterial calcification, represented by the bright white dripping wax, which could signal more severe atherosclerotic disease, predisposing to mesenteric thrombosis. And finally, mesenteric artery occlusion, which can be identified as a lack of enhancement of the vasculature with timed IV contrast injection, represented by this unlit candle here. See that unmarked grave? What if the CT is non-diagnostic, but suspicion for mesenteric ischemia is still high? In this scene, we'll represent a non-diagnostic CT as an unmarked grave. Time for mesenteric angiography. Just shoot some dye in there and take a peek. In the case of non-occlusive mesenteric ischemia, for example, CT isn't that great at finding the area of vasoconstriction, and is instead mainly used to rule out any sign of vascular occlusion. Mesenteric angiography, on the other hand, more reliably demonstrates the characteristic narrowing, spasm, and filling defects associated with non-occlusive mesenteric ischemia. Because of the dynamic nature of non-occlusive vasospasm, however, disease can still be missed. Spasming skeleton hand grabbing an arterial candle. Good symbol for mesenteric artery spasm? Sure. Unnecessarily grotesque? Probably. And that brings us to the end of the sketch. What? No. We are not done with this Mexican masquerade, mis amigos. Sit tight for part 2, the management of mesenteric and colonic ischemia.